our debates and discussions on what it means to imagine a health system, we may well be talking about a health system that isn't anchored in core rights and doesn't effectively shape or respond to the complexities of the dynamics between citizens and the public health system, between citizens and their rights in the context of health. And it is in that spirit that we felt it was extremely important for us to have a dialogue on why debates on universal healthcare or health coverage need to intersect with the dialogues and discourse on rights. In India specifically, the courts have played a very, very important role in determining the contours of how policy engages with health, the limits and aspirations of what India's public health system should be about, and how it engages with citizens. And therefore, it is even more important for us to bring the discourse on rights front and center into the discourse on policy and healthcare. So it's in that spirit that we requested C-Help, Vivek and Shubhangi here to organize today's discussion. Thank you very much, both of you, for doing this, and we're looking forward to learning from you. And thank you very, very much to our extremely esteemed group of panelists. It's a real privilege for us at the Lancet Commission to be able to host all of you and learn from you. And I hope that not only through the course of today's conversation, but over the course of the Commission's work itself, that we get the opportunity to engage more with you and bring to the table some of the ideas that all of you have pushed us to think about. So thank you, and over to you, Vivek and Shivangi, to take us forward. Shivangi, sorry, you're on mute.
Sorry about that. Thank you, Yamini, for setting the context of this webinar. We are fortunate to have with us today an exciting array of eminent speakers. A lot can be said about each of the panelists, who are all stalwarts in the fields, but I'm going to keep the introductions short as we have a tight schedule. Their longer bios are posted in the chat box for the benefit of our audience. So we have with us Mr. Dainius Puras. He's a professor of child and adolescent psychiatry and public mental health at Vilnius University, Lithuania. He's also a former UN Special Rapporteur on the right to physical and mental health 2014 to 2020. Dr. Gita Sen, Director and Distinguished Professor, Ramalinga Swamy Center on Equity and Social Determinants of Health, PHFI, Bangalore. She was also a member of the high-level expert group, which recommended a roadmap for UHC in India in 2011. Vivek Devan, coordinator at C-Help, ILS Law College, Pune, and a lawyer who has worked on the intersections of law, health, and rights for over 2 decades. And finally, Meera Sangamitra, an independent human rights activist. She has been associated with National Alliance for People's Movements for over a decade and has worked on several social justice issues, including women's rights and transgender movements. Before we hear from our panelists, a couple of logistical announcements. Each panelist will have 12 minutes to speak. Pooja will alert you at around 10 minutes for you to start winding up your talk. The audience members can post questions addressed to specific panelists in the Q&A box, which will be taken up in the last session, but please do keep them short. So let's dive straight in. I first invite Professor Puras to talk about the interlinkages between right to health and UHC as informed by international human rights law obligations.
Thank you. It is a great pleasure for me to be part of this very meaningful event. I will share my experience after serving for last 6 years as a UN Special Rapporteur on the right to physical and mental health. As we know, the process of pursuing the transition to universal health coverage is not easy, and one of important issues is to identify all challenges and pitfalls awaiting stakeholders on this way. So the good news is this global powerful consensus on the need why universal health coverage. Now we need to speak about how to do this and what could be obligatory safeguards ensuring the success of this process and eliminating the risks of failures. As we know, universal health coverage is a key dimension of the 2030 Agenda commitment toward achieving healthy lives and well-being for all at all ages. And goal 3 includes an explicit commitment to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines. Also to ensure access to sexual and reproductive health care services, including for family planning, information, and education. So these are well-known targets, 3.8 and 3.7. These are important targets. However, this is all not enough because these targets do not make explicit commitments to confer priority to the poor and marginalized, either when coverage is expanded or which services should be provided when there is discussion about services. Now with pandemic, COVID-19 pandemic, we have new challenges, as you all know, about prioritizing, and I just want to highlight that without human rights-based approach, there is always a risk that universal health coverage efforts may entrench inequality. So prioritization and participation of the world's most vulnerable is vital to both defining and achieving equitable universal health coverage. This is also consistent with core obligations and the right to health to guarantee access to health services without discrimination and to take deliberate and targeted and concrete steps to ensure progressive realization of the right to health. Just moving to some examples, the right to health recognizes the importance of prioritizing investments in primary and preventive care, and I should say social medicine, which benefits a far longer sector of population over expensive specialized services, and investing in primary health care prevents illnesses, promotes physical and mental health, and in turn reduces the need for specialized care. Health-related policies, as we know, the implementation of good ideas has always been complicated. Although universal health coverage looks like a simple idea based on common sense and the need for basic health care to reach everyone, it is important to issue a warning against any simplified way of addressing the universal health coverage and the process of reaching it. Actually, all elements of the right to health analytical framework developed by my predecessors, first and second special rapporteurs, Paul Hunt and Anand Grover, need to be taken very seriously in this regard. If any of these elements are for some reasons ignored or not adequately addressed, the process of reaching universal health coverage may be wrong. Let me just mention some examples which may illustrate the complexity of the goal ahead. First, accountability and transparency need to be seriously addressed. Healthcare systems remain seriously affected globally in many countries, and this alarming tendency affected by corruption globally. And this alarming tendency needs to be abandoned in the process of reaching SDGs and universal health coverage. More specifically, meaningful involvement of citizens through partnerships between governments and civil society organizations could be a very good remedy to substantially promote transparency and accountability. And very often NGOs can do not only advocacy, they can be very good and effective service providers. While there are many important managerial and economic questions to be addressed in the process of reaching the universal health coverage, I would like to highlight other important issues which should not be ignored by policymakers. These are principles of non-discrimination, accountability, participation, and empowerment. Also informed consent and the need to go beyond narrow biomedical model so that holistic, equitable, and ethical care is provided to everyone, and especially to those belonging to vulnerable and disadvantaged groups. Selective approach to human rights is too often used by many states to achieve short-term goals, to pick low-hanging fruits, including the one aimed at improving health indicators. This has led to serious imbalances and power asymmetries in health-related policies and services when some rights and needs have been promoted and protected at the expense of other ones. It is important to identify such imbalances and properly address them. For example, focusing mainly on the access to essential medicines and vaccines, which is, we know, very important, especially now with COVID, as the huge importance of their accessibility so well recognized, but this still would be too narrow approach for reaching SDGs and universal health coverage. For example, investments in child health need to prioritize the right to health and holistic development, which is as important as the right to survival. Universal health coverage needs to include sexual and reproductive health rights, especially if we wish to empower children and adolescents for healthy and responsible adulthood and parenthood. Promotion of health and healthy development, as well as protection from all forms of violence in childhood and in later stage of life, includes many essential public health, social, and psychosocial interventions. Yes, they are of non-biomedical nature, but they should not be seen as some kind of luxury when considering what should be covered by universal health coverage. Furthermore, sustainable development goals and universal health coverage cannot be reached if drug policies remain punitive, as they are now very often, or if palliative care is not available. SDGs and universal health coverage be reached if mental health needs of everyone are not taken as seriously as physical health needs, and if mental health policies and services do not abandon their reliance on institutionalization, excessive medicalization, paternalism, and the tendency of too often coercion in the name of medicine. So these and other challenges can only be effectively addressed if all elements and principles of the right to health framework are mainstreamed in health policy formulation and implementation. So to formulate is often easier, to implement is more difficult, more pitfalls and challenges. And this is why we should always include non-discrimination, equality, participation, and accountability. Just 2 words about the private sector. Private sector should not be demonized. Private sector should be involved in national health systems so that it hold it accountable. And then private sector can and must contribute effectively to realization of the right to health, including in reaching universal health coverage. So we come back to the core of what the right to health is about, and to the understanding that it is an indivisible part of universal human rights. I mean, to health is indivisible part of universal human rights. As we all have now in moving towards SDGs and universal health coverage, we need to take on board the words of famous HIV/AIDS activist Jonathan Mann, who told that the human rights framework provides a more useful approach for analyzing and responding to modern public health challenges than any framework thus far available within biomedical tradition. And what has been achieved globally in addressing HIV/AIDS needs now to be replicated with the same level of global commitment and passion for all remaining global health concerns, such as addressing social determinants of health, burden of non-communicable but also communicable diseases, diseases of poverty, mental health challenges, and many other global health issues. So any departure from universal human rights principles and modern public health approach would be detrimental for the success of this process, I mean, of reaching universal health coverage. So these were main things which I wanted to highlight. This is my main impressions from working on thematic reports, but especially on visiting countries with official and other visits in all the regions. We have regional specifics, but most important are global principles, especially human rights based approach. Thank you.
Shivangi, you're on mute, Shivangi.
Sorry. Thank you, Professor Puras. You made it amply clear that the UN General Assembly and World Health Assembly resolutions have consistently reiterated that the right to health is the overarching framework for UHC. It must follow that states should act in conformity with their obligations to respect, protect, and fulfill the right to health when designing and implementing UHC. Well, with that, I now invite Professor Gita Sen to share her perspectives on social determinants of health and UHC from a gender lens.
Thanks very much, Shivangi. I am, before I share my screen, I just want to say a couple of things. One is just to reiterate something that Dr. Puras mentioned, which is that without a rights-based approach, UHC may actually end up reinforcing inequality. And I think we have the particular challenge here that because that famous UHC cube that WHO put out many, many years ago tells you where we should be going, but doesn't tell us how, it can often be done in a way that where states actually find it convenient to pick the lowest hanging fruit. And if they do that, then in fact, those who are the most marginalized and the most at risk of not having rights to health will be the ones who get pushed further and further behind. And we have many examples of that. This is not something I plan to discuss myself in this talk. Let me share my screen and run you through this. I've said from lip service to realizing the right to health. And I hope to show you in a minute why I'm calling it this. So the core concerns on women and gender equity in health for a long time can be broadly seen to be threefold. First, over-focus by public programs on women as childbearers, receptacles for babies, fetuses, breast milk, you name it. The need to address these, but also to go beyond reproductive health and to include a life course approach. Secondly, to recognize women as rights holders with corresponding duty bearers, so that we can start parsing exactly what does the right to health really mean for girls and women. And thirdly, the need to go beyond gender equality as a platitude, which it has become in too many places and cases, to which lip service is paid, how to move to real changes on the ground. And I hope to say a few things about each of those. So lessons from my own prior involvement on these sets of questions I draw from two places. One, the Women and Gender Equity Knowledge Network that I co-chaired for the WHO's Commission on Social Determinants of Health. That experience was fascinating because it was at a time in the 2000s when in fact gender equity in health had not been sufficiently acknowledged and recognized, or if it was seen as something secondary to economic inequality, poverty, household-based inequalities, and so on and so forth. And my experience, to put it bluntly and quickly, with working with that knowledge network for that commission, is that although that network had over 60 people, core members participating in the network, in the end, when the report of the commission overall came out, it didn't really pay very much attention to all of the very hard work that had gone into the workings of that commission. Hence, my concerns about lip service. Secondly, the Planning Commission's high-level expert group, and I hope to say a little bit more about this going forward. But broadly, what I've understood is that there's many ways in which one can miss the policy bus, or end up reinventing the wheel over and over and over and over again, saying the same things in different words to different audiences, but really not making too much headway. So the HLEG itself had a bunch of recommendations when it came to gender. Broadly, these were improving access. Secondly, recognizing women's role as health providers. Thirdly, strengthening data analysis and monitoring and evaluation. And fourthly, to support and promote the rights of girls and women to health in families and communities and programs and policies. And then on each of these, there were detailed recommendations, which I won't go to. Broadly, I would still say that the HLEG, in terms of these recommendations, was not too far off. Although, 10 years plus on, one might nuance, modify, and so on, what it was, those recommendations considerably. Where do I think we, in a sense, may have missed the bus or be fated to reinventing the wheel? I think it is that one fundamental question is being skirted. We go round and round it without naming it clearly. And I believe now that when we talk about rights-based approaches, we need to name that. What is that? Power. We don't talk enough about power. We don't talk about the role of power, neither at the policy level, nor at the level of programs, nor at the level of communities on the ground enough so that we can actually not keep having to reinvent the wheel. Let me say a bit more about what I mean by this. Why focus on power? Because power often derives from exactly those deep structural inequalities that are not easy to change. Hardy perennials in this country, gender, caste, and others being added to those like religion, but which haven't been such a perennial over millennia like gender and caste have been. Secondly, power, as we know, seeps into norms and beliefs, into what we know as truth and what we believe about the world and our role within it. And thirdly, power, gender power exists at multiple levels that reinforce each other, from the household right up to legislatures, executives, judiciaries, and so on. And these are the reasons why we actually need to name and address power explicitly and not allow it to continue to hide in the crevices and of the UHC discussion. Gender power and health. Our health depends not only on our sex, but also on gender power systems and hierarchies. Gender power shapes which and whose health needs are recognized and prioritized, who gets access to resources and services, what quality those are, and who works at which level of the hierarchy of health workers versus frontline specialists versus frontline workers versus unpaid healthcare workers at home. in the work of the Knowledge Network for the WHO Commission, we had actually come up with what I believe is a relatively simple framework, which now in the context of our work on COVID-19, we have adapted and modified a bit 10 years later on. I won't go into all of this, but simply say that it has two causal blocks, and then one is the consequences below. Structural causes, which include those larger economic political processes interacting with the forms of social, gender, and other forms of stratification and subordination, those long-standing inequalities. Secondly, and this is the most crucial for us here, intermediary health factors, which I believe operate at 4 levels, which we need to bear in mind. First, discriminatory values, norms, practices, and behaviors. Secondly, differential exposures, vulnerabilities to disease, disability, etc. These could be biosocial or they could be sex, gender factors. Thirdly, continuing biases in health systems and policies. And fourthly, reinforcing those biases in health research. All of these 4 intermediary factors interact with each other, reinforce each other, sometimes, but rarely counteract each other. And we need to pay attention to the way in which all of these work if we are really not to keep having to reinvent the wheel. So we need what in recent work we've called power-focused realist evaluations. And there are 4 sets of questions in any context that are essential. They're necessary, but not sufficient to the particular context. First, dimensions and sources of power. In any health context, access to resources, knowledge, control over decisions, in any health context, including service provision. Secondly, how power is built into what we call the artifacts of a program strategy. How is power built into a program's objectives, into its rules, into its procedures, into its financing methods? These are things we don't sufficiently go into. And it often is the reason why lip service to grand notions of equity, equality, universality, gender justice, and so on, stated at the level of principles, get sabotaged under the subterfuge of the nitty-gritty of program strategies. And we need to look at how power is built into these. Thirdly, what does this mean for the incentives, disincentives, and behaviors that result in terms of health providers, in terms of health seekers, in terms of people within households and families, and what are the consequences thereof for policy and program outcomes? Let me give one quick example if I still have the time, and that is just an illustration what this means in the context, let's say, of the quality of institutional deliveries in India. We all know that the numbers of institution deliveries, thanks to NRHM, have gone up dramatically. We also know that questions about what is actually going down in the name of institutional deliveries is open to question. Still, in my own mind, there's absolutely no question, but these have played a role in reducing the numbers of maternal deaths. But what about quality? And we have the Lakshya program of the government today, which claims to be moving towards improving quality. And yet, a good look at Lakshya tells us that it remains focused, as most government programs tend to do, on the bricks and mortar, building better health centers, ensuring that there may be a toilet, and so on, but not to the software of power, where power is embedded. So we need to ask the following kinds of questions. what women confront in public: overcrowding, routine verbal abuse, lack of cleanliness or privacy, routine episiotomies, pushing on the abdomen to hasten delivery. And I'm naming only a few. And I'm saying this on the basis of tangible research that my team and I have done. So this is what women confront in public services, despite all of the language of improving quality, versus on the other side, the private sector, highly doubtful quality, lack of accountability, over-focus on C-sections and hysterectomies. Secondly, what does it mean? WHO guidelines, and they exist. There's excellent WHO guidelines, and there are very good domestic guidelines as well that follow from these, are often observed in the breach. When we did our fieldwork, the head of department at teaching hospitals would tell us, oh yes, we absolutely follow the guidelines. The realities in the labor wards, and in fact, very openly, the people who are actually doing the deliveries in the labor wards, the interns, the postgraduate researchers who are actually the ones providing services in the labor wards will tell you, well, sometimes we do, sometimes we don't. Do you allow or do you promote pushing on a woman's abdomen, which is an absolute no, according to the guidelines? Sometimes we do, sometimes we don't. So the reality versus what everybody at another level is claiming is what gets done. Thirdly, how can a power analysis help? Start with what a poor Dalit or Muslim woman confronts when she goes in for an institutional delivery. Then move to why she confronts it, and then to how to change it. I don't have time to go into this in greater detail, but I wanted to illustrate to you that, in fact, if we have to move from the level of repeating ourselves and lip service to actually making concrete changes happen, we need focus very centrally, not just on power as an abstract category, but power relations as they in fact adhere and are embedded in health systems. Thank you.
Thank you, Dr. Sen. The conceptual push to understand power and its role in thinking about UHC programs that you've highlighted is probably one of the most crucial questions facing not just law and policy makers, but civil society as well. This though leads us in an interesting way to Vivek's presentation, as we often consider laws and jurisprudence as a way to deal with some of the questions you've posed on power. Vivek.
Thanks, Shivangi. I think, yes, indeed, my presentation will focus on, I think, the law largely and the ways in which the courts have really engaged on issues of health. And I must say that when Dr. Sen spoke about power-focused realist evaluations, it made me think about really immediately how, as the discipline of law, we really rarely kind of go into that kind of a granular analysis of some of these social justice issues. The courts ultimately are places where general solutions are offered, orders are issued, directions are issued, but the granular understanding of how power plays out, for instance, in communities is very rarely does the court get the opportunity to really delve deep into. So I think what the law can do then is really support UHC and show ways in which, and probably hint towards how rights-based approaches and the right to health can be a framework which supports the larger kind of program. But I will really focus on largely on how the courts have stepped in the context of health rights generally and the right to health in particular, and give a broad description of that in my 10 to 12 minutes. And then I'd like to talk a little bit about how statutory law plays or does not play a role And in doing so, also speak towards some of the points which the high-level expert group on universal health coverage, which Dr. Sen was part of, has actually raised certain critical aspects of, and where the law seems possibly not to tackle some of those aspects very well, and where some of that needs to be addressed. So let me start, of course, with the Constitution, where it really all begins. I think the audience probably is not an audience of lawyers entirely, and so I'll kind of spend a little time just explaining very, very briefly what that architecture is. And that architecture really emerges from Article 21 in Part 3 of the Constitution, which guarantees that no person shall be deprived of his life or personal liberty, except according to procedure established by law. So this is really the fountainhead from which when we talk about the right to life, a lot of the other rights have emerged. And the Supreme Court has read, not just the Supreme Court, but other constitutional courts in India has read the fundamental right to health into Article 21. And it has done so by also looking at two other articles in our Constitution. So Article 21, which forms part of our fundamental rights, which is really the core of our legal framework. And then there is another portion of the Constitution which refers to directive principles of state policy, which is really guidance that is offered by the Constitution about how government should be actually implementing policy and the guiding principles by which policy should be devised. And so the court has looked at both Article 21 and a couple of these other articles. One of them is Article 39E, which requires the states to ensure that health and strength of workers, men and women, and the tender age of children are not abused. And Article 47, which says that the state shall regard the raising of the level of nutrition and standards of living and the improvement of public health is among its primary duties. So, this is where really the thrust of any attempt to try and give shape to health-based rights has really come from within the citizenry, within civil society, etc. And it has been the constant kind of approach to the judiciary which has fine-tuned and articulated this understanding of what the right to health may or may not contain. And so I think in 2021 today, we have a much better sense of what these contents are, even though it is not really expressed in very clear terms in a statute or in very clear terms in a section of the law. One of the earliest articulations of how Article 21 is relevant in relation to a health issue emerged in a case where the Supreme Court said that the right to life foists an obligation on not just the state, but also the private sector to save life in emergency situations. So this was a case where someone was denied emergency health services and succumbed. And the court said that there's no question that access to such services is absolutely vital to preserve the right to life, which is explicitly stated in Article 21. And therefore, emergency care became something that had to be actually something which was incumbent on both the state and the private sector to protect. So this was an interesting thing, and I emphasize private sector here because I will come hopefully to how that has not necessarily been the focus of the courts since this early ruling in 1989. So such interpretation has been really used to expand the meaning of Article 21, like I just said, which is the right to life, to include all kinds of other things, everything from human dignity to essential freedoms and entitlements like clean water, food security, healthcare, of course, which we'll go into a little more deeply, sanitation, housing, livelihoods. So all of this really now encompasses the right to life and liberty. And when those of us who work on these issues actually claim rights constitutionally, we frame them within Article 21, and where the understanding of health rights has been fleshed out even more. So there are various aspects to the right to health. I think there are way too much to cover in the limited time one has, but I wanted to highlight a few judgments which are relevant in the context of particularly universal health coverage. I think there are aspects of these judgments which will resonate when we're thinking of universal health coverage and its contents and what really UHC should comprise of. One of those aspects is, for instance, the issue of the access to medicines, access to just medicines to obtain better health. It's an issue that courts have actually grappled with and recognized and acted on to ensure the fulfillment of the right to health. So, for instance, in 2017, there was a case where the Delhi High Court declared that access to life-saving medicines for rare diseases is inherent to the right to life as a component of the right to health under Article 21. And by ruling as such, it directed the state government to take steps to provide access to affordable medicines and treatment in the case of baby Devanand, which, of course, has been actually discussed and is an important articulation of how treatment access is fundamental to the right to life. Similarly, actually, the same court, the Delhi High Court, also conducted what is known as a continuing mandamus hearing, which is where it actually supervised the mandatory implementation of its orders over time to monitor the finalization of the national policy for rare diseases by the Ministry of Health and Family Welfare. And the court did so because it wanted to oversee that its directions were actually being followed and implemented. So there also you had a case where part of the national policy for rare diseases was around access to treatment in that context. Similarly, in more broader context, courts have said a lot on access to treatment and healthcare. In the more famous case of National Legal Services Authority versus Union of India, NALSA as it's known, where the court established the equality of transgender persons, it also said that transgender persons have access to HIV-related healthcare services, mental health care services, and public health facilities and sanitation services. So although it did not frame it as a right to health issue, it clearly was giving meaning to the constitutional rights of transgender persons by referring to specific health areas. It also has, and this is an area which I think is has come to the fore in the context of COVID-19, certainly, around the issue of occupational health and safety of workers. And of course, in the case of COVID-19, frontline healthcare workers, where the Supreme Court has directed, not in the context of COVID, of course, but earlier, has directed employers to undertake appropriate measures for occupational health and safety of workers and ordered them to provide free medical consultations and treatment until cured or for lifetime for occupational diseases. Now, again, this is largely in the context of government employment. And I again want to emphasize that because I think Dr. Puras mentioned the private sector. And I think the private sector is one big area through which healthcare is delivered, which is not necessarily very clearly governed by legal frameworks, especially around right to health issues. Then there are other issues of access apart from medicines, which the courts have said some really important things around. Relevant to UHC is the issue of the right to access health insurance as part of the right to health. This came up in the case of genetic conditions in Jayaprakash Tayal's case, or mental health conditions in another case, Shikha Nishchal's case. So you have the right to access health insurance, which cannot be denied just because you have a specific genetic condition which is exclusionary, where the policy is exclusionary, or if you have a mental health condition where a policy is exclusionary. Similarly, in quite a few cases around right to sexual and reproductive health, the courts have said that sexual and reproductive health rights are integral to the right to health. In one particular case around unsanitary and unethical sterilization procedures against on women. Then the courts have talked also and gone into, really policy issues, not necessarily their domain, but have had to kind of intervene. And this is in the context of deployment of human resources for health. So, for instance, reservation and recruitment of healthcare workers from rural communities as an effective policy to fulfill right to health obligations towards rural communities by ensuring that there's medical staff available and there is a facilitation of access to healthcare goods and services in places where otherwise access is challenging. So that's an interesting intervention by the court where it has actually stepped in and said the state needs to reallocate its resources in terms of how it designs policy to ensure that competent health cadres are available in rural contexts. And again, very relevant in the context of universal health coverage. There's one whole other area which I will touch on very briefly. I already see that I'm running out of time, which is the area of social determinants of health. I think Dr. Sen spoke about this and certainly referred to the context of gender quite clearly. But there are issues around social determinants of health that have made the link between larger factors at play that affect the right to health. So for instance, I'll give you a couple of examples where the Bombay High Court has recognized that the right to health includes underlying determinants of health like access to public toilets and sanitation facilities. And it has done so particularly to ensure that special measures are made to facilitate women's access to public toilets and sanitation facilities, because it hinders the ability of a city and its citizens to really enjoy rights fully. The Supreme Court has held that the right to food is an integral component of the right to health under Article 21, and therefore now looking more broadly as health being informed by these other social determinants. So that's a really important direction in which the court has gone in kind of not necessarily framing it as a right to health issue, but certainly making the links with the right to life. And I think as health activists and people who advocate the right to health, these are important kind of pointers towards how right to health can be more fully realized. So this is some of the stuff that I thought is important to highlight in my limited time. I should say 2 or 3 more things though. Shivangi, I hope I have a couple of minutes more. One is that I think while the court has looked at the Constitution, it has also looked at the International Covenant on Economic, Social, and Cultural Rights. And it is that international covenant which India is signatory to. And it is that international covenant which actually very clearly articulates the right to health as a fundamental human right. And the courts have often leaned on that to actually give a fuller understanding to what the right to health really comprises of. And Dr. Puras mentioned this briefly also, but there are certain elements which have been infused in that right under the international covenant. And those are the ones which really the courts have gone more deeply into in analyzing some of the social determinants which are linked to the right to health. There is, of course, COVID of the last 18 months, and we have seen the courts getting more and more active in many cases. For instance, the Bombay High Court has found gross negligence by a government hospital where a partially decomposed body was found of a person who had died of COVID. And the courts said that actually there's a right to health, which is mandated under Article 21, and timely medical treatment is part of that right to health. Similarly, courts have said, Madras High Court has said that persons with disabilities should be given priority in vaccination, and vaccination centers must be made accessible as part of the right to health of people who are disabled. Again, and a really important component, I think, which gets lost often in conversations on UHC2, but also in the context of delivering fully on the right to health, is the issue of right to information, where the Patna High Court has directed the state government to provide online information to public on the number of deaths that have taken place due to COVID as part of actually their fundamental right to information, very closely linked to the right to health. Capping of fees of charges by private hospitals is another point on which courts have intervened and actually capped fees, which was a really telling moment in the last 18 months around where the right to health trumped other kind of issues and so-called priorities. And so that this gives hopefully a kind of overall view of where the courts have come in, and it's largely been the courts which have come in. But I'd like to touch on one more thing before I close, which is that there is also statutory law. So we have the Constitution of India, but we have a few statutory laws which have actually enabled the right to health in a much more meaningful way. There are many of late, particularly there's the Disabilities Act, there's the Mental Health Care Act, there is the Protection of Women from Domestic Violence, and there's the Transgender Persons Act. But I just want to focus on the HIV Act. And I want to do so largely because there are some aspects which the high-level expert group on universal health coverage has noted that are of great relevance in relation to delivering on a robust right to health and UHC. And I think the judicial action on these areas has been rather limited. And I wanted to highlight these 3 or 4 because I think statutory law in particular, for instance, the HIV Act, tries to address this. I think the courts have, like I've described, looked at various issues and said, well, this is part of the right to health, or that is a health right. But the how-to of delivering on the right to health has received less attention from the court. And so 4 issues have come up in the context of the HIV Act. One is on governance of the private sector. It's the first law followed closely by the Mental Health Care Act, where the private sector was included within an anti-discrimination framework. So the private sector became accountable for the manner in which it was delivering healthcare in the context of HIV. I think that's a really important issue that the high-level expert group talks about. The other is citizen participation, which I think Dr. Puras mentioned around accountability and transparency and involvement of citizens. There are ways in which that has been attempted through the HIV Act, which could be a model and suggest ways forward for a UHC which has these components, which are inherent to delivery of the right to health. The third is the issue of grievance redress. That grievance redress has to be effective and localized. There is no point in trying to provide a right where justice is almost inaccessible, because access to justice is as much of a right as anything else. And so trying to create simple mechanisms for grievance redress, if, for instance, universal health coverage is not accessible to someone. And finally, and I think the courts have tried to do this a bit, and certainly Dr. Sen and Dr. Puras both spoke about this, is focusing on the needs of the marginalized. I think the HIV Act very much is focused on that. And again, I think these are the 3 or 4 groundings which I think are essential, apart from in terms of the how-tos for a right to health really to have some effect in the context of legal frameworks and universal health coverage. Thanks.
Thank you, Vivek. Your talk really sets out quite well that the right to health is in fact a core constitutional right and has been interpreted by the Indian courts expansively in accordance with the right to health framework in international law that you talked about, and also what Professor Puras had mentioned. And that courts will step in when the right is violated and give directions to expand public health programs. This makes it all the more important then that any UHC program or framework be examined from a right to health lens too. With that, I finally invite Meera Sangamitra. Her talk will be on providing meaning to rights-based approaches to UHC from marginalized contexts. Meera.
Thank you, Shivangi, Yamini, and Vivek, of course, and all the co-panelists. I've been very keenly listening to all of your presentations, and a lot of things, in fact, resonate when we, as part of campaigns for universal access to healthcare, articulate and speak of. And I think what Dr. Sen, she literally hit the nail on the head when she spoke of the whole notion of power and why it needs to be center stage in understanding a lot of the dynamics and politics around access or the denial to healthcare. So with that context, I would want to start off very briefly with an observation that in 2021, we are exactly 3 decades since the whole regime of privatization and liberalization was set off in India. And it's important, I think, to really acknowledge as to, because when we talk of universalization of healthcare or other intensifying access to public health and other services in the public sector, it's important to also look at how the architecture that existed for the last 3 years or the policy measures that were followed, in fact, to a large extent contributed to dilution of access to access to all these services, to these rights, basically to these entitlements, and denial, structural denial over decades. And it is therefore important to state very emphatically that the regime of privatization has not worked, and it has in fact been counterproductive at the end of, if one really reviews this entire policy framework at the end of 3 decades, it's very, very clear that whether in the context of healthcare, whether in the context of education, whether in other contexts, it is very amply clear that privatization and liberalization has, and COVID has in fact added, of course, a very thick layer of vulnerability further to all these marginalized communities. And when we speak of marginalized communities, these are not minorities, but actually the majority of our country, because when we speak of the broader Bahujan umbrella, it includes all the categories that one really needs to speak of. 80% of Dalits, Adivasis, transgender persons, queer persons, women across all categories, Muslims and other minorities, Vimukta, NT-DNT communities, persons, not just political prisoners, but people who are into prisons, because a lot of times those who are in prisons also and do not have access to healthcare over there also are from a lot of marginalized communities, so on and so forth, or persons with disabilities, children, etc. So when we talk of healthcare, am I audible? Shivangi?
Yes, absolutely.
Sorry. So when we speak of access to healthcare, it is something that that matters to all these categories of the population who form the bulk of our 80% of our population. But when the policy is determined, or in fact, not just policies, even Vivek spoke extensively about the legal frameworks and the experiences with the judiciary as well, but I would say it has honestly been mixed. In some ways, yes, the rights regime has been reinforced, but on certain occasions, it has also been, there's been a lot of oscillation between rights and rhetoric as well. So it's also important to note that, especially with the Supreme Court, maybe many times, there has been a lot of hope often from the high courts, and where we've had certain good orders in specific contexts, and it has been possible to assert some of these rights and connect it with the frameworks of healthcare obligation of the states. But it has also been very, very challenging, because many times these get limited to very specific contexts, and any attempt to kind of use these progressive rulings to a broader context does not really yield much result. So there has also been that kind of experience that practitioners have had on the ground. So having said that, I would want to specifically also a bit focus on some of the marginalized communities that I referred to. One could begin with the trans community itself. It's true that, yes, after, almost 70 years, 75 years since the constitution, in 2014, we had NALSA. NALSA did recognize in some ways the right to health services without discrimination, the right of the responsibility of the state to actually guarantee many of these services to transgender communities, who are one of the most marginalized sections of our population to this date. And we've seen, and in fact, it's not just, COVID or no COVID, certain structures of discrimination have always existed. Lack of access to public healthcare structures has always existed for some of these communities. So it has, even at the very level of entry, it is so difficult to actually access these services. Of course, there has been a lot of work, and where there has been some amount of work or politicization or work within and with the communities, one has been able to push and hold local health facilities and institutions accountable to principles of non-discrimination. But if one looks at it in a broader framework and in terms of the accountability of the state, then all of these basic things, right? For instance, there are very specific requirements, in addition to all the general requirements that trans people have as equal citizens, specific requirements around psychosocial support. There's absolutely no mental health support, or there is no imagination of the need for any form of mental health support, to hormonal therapy, which is not seen as part of the as a public health need for trans people, to gender reassignment surgeries and other forms of interventions, so on and so forth. So there are also very many specifics that trans people require as part of their right to a life with dignity and life of equality. But a lot of these things are still not part of I mean, despite now, yes, we do have the 2019 Act and the rules and all of that, but I mean, that's a longer conversation about, it's one step forward, two steps backward kind of a experience we've had. But even beyond that, what is it that this does to trans people on the ground in terms of access to healthcare services? In fact, what we've also seen is many times, very certain states, it's possible to push certain things at the level of the state governments and the state policy to maybe get something at a pan-Indian level might not always be possible, or not be even ideal for the kind of diverse nation that we are. And many times very specific policy interventions that have happened. This is true also of other sectors, but I speak right now in the specific context of health. Measures that say the Tamil Nadu government has taken, for instance, or the Kerala government has taken, although one would still wish more on those fronts as well. But even those limited kinds of interventions have not happened beyond some of these states. So there are all these experiences that one has in the context of transgender people. But I think it's also important to locate not just the questions and rights of trans persons, but also the overall question of right to health within a political framework of the working class population. And the migrant workers crisis is again a very graphic example of how the whole question of lack of livelihood security, lack of income security, lack of social security is so deeply interlinked with the question of access to public health, right? So we do, I mean, again, there are laws since the Migrant Workers Act to the 2008 Social Security Act to now the Supreme Court having woken up very late during last year's pandemic and then having passed some orders, which again, to a large extent, could not be implemented on the ground. So there's this whole experience as well one has, right? So within this context, if one looks at how 93% of our working population, and within that I would definitely include transgender people as working class communities, and also all the other sections of our population as well, not having access to social security, starting from on the one hand, we have a whole surveillance regime and data tracking and all, but on the other hand, the state still does not have a proper mechanism to actually identify people, and based on that identification, provide essential services to many of these communities. For instance, we saw even in the context of the trans population last year, the COVID relief which was given, that too after a lot of push and pursuit, was just for 1% of the overall trans population in the country, and that the estimate of the trans population was also of the 2011 census, much before the NALSA. So definitely, I mean, the population is much huger, and even the bare minimum income support that went to, one-time support that went to the trans population was only 1% of the entire population in the country. So one can actually imagine that, I mean, there is such a lack of imagination at the level of the central government in particular, but governments in general, as to how does one in fact identify these populations that are so vulnerable and neglected, and why they would need specific forms of support. For instance, many times we are still having to argue as to why a pension support is necessary. Some states, like say Andhra Pradesh, have brought forth pension support, but in addition to healthcare, strengthening the healthcare system, it's also important to provide these forms of social security support, which is still not available for a lot of these populations. So trans people, for instance, in Andhra Pradesh do have now for a couple of years pension support. But again, there are a whole list of conditions in that they say you have to be below the poverty line, as if trans people are above the poverty line. Most are below the poverty line. In fact, they say you have to mandatorily undergo the SRS, and only then you will have access to the pensions. They say you have to give up on begging and sex work, as if other livelihood options are readily being provided by the state. So all these conditions apply, frameworks that are put in, make even the limited schemes less accessible to to communities that are vulnerable. So this is just one example, case in example, but there are these kinds of riders that governments put in as well with schemes that come in. So therefore, it becomes all the more important that on the one hand, while we continue to argue for and push for universalization of healthcare, which we think, and across movements, this is a demand that has strengthened, especially in the past few years, to look at how lack of healthcare in the lack of universalization of healthcare had actually impacted some of these communities in very, very specific ways. For instance, just a couple of weeks back, we were having a meeting with some of the nomadic community youth, and they were speaking of how lack of documentation within those communities actually meant that, they were access to healthcare because of lack of documentation was becoming such a basic issue. So there are so many of these specifics that have not become part of the imagination of the policy regime. But what we are also seeing is very worryingly despite these 30 years of experience, negative experience with privatization at all, we are also seeing a further push for privatization with Ayushman Bharat and the district hospitals, the suggestion for district hospitals to be a graded privatization. So all of these things, so where are we headed is definitely a cause of concern. With this government, honestly, the other cause of concern is also, of course, yes, one must value and respect traditional knowledge and traditional medical knowledge, but there is a thin line between valuing traditional knowledge and how they're actually going on to the other side of, really pushing unscientific methods of healthcare and medical interventions, and what does that mean to our public healthcare system, and especially for vulnerable populations, is something that I think should be part of our agendas. And we should also equally talk about, when we speak of rights of workers, informal workers largely, there was a reference to frontline workers. Many times there is a warriorization of the frontline workers, but what actually happens is the everyday concerns of, every single day we are seeing the ASHA workers or the Anganwadi workers organizing dharna in some part of the country. So on the one hand, there is an increasing feminization of all these frontline workforce happening. What we call infamously as the paraization, right? So you are the para teachers, the para healthcare workers. So all of these World Bank models have been pushed and imposed and being institutionalized and being celebrated as warriors, whereas the basic work security that needs to be provided to these constituencies is not there, and that then directly has an implication on the kinds of services that they're able to provide to a broader mass of people who are already vulnerable because of other social locations. So it's important maybe to connect, when we speak of access to public healthcare and universalization of public health, to be able to connect many of these realities on the ground as well, and frame our not just asks, but one doesn't know who to ask with the current regime, but it's important to build a political narrative around why certain things have not worked so far. So what needs to be the road ahead in terms of framing a public health campaign and the need for nationalization of healthcare. When we talk of nationalization, we are again not talking of centralization. We are talking of the state being accountable for people's healthcare, all forms of healthcare. So I think it is with these caveats that we need to also walk the path of nationalization and the universalization demand. And yeah, let's see how we actually, it's a difficult struggle, and we are constantly in many of the conversations across communities, and because of lack of time, I think I've already overshot my time. So I'm not referring to the specifics of, say, the displaced communities or migrant populations, the kinds of concerns that they have. The absolutely pathetic conditions in resettlement colonies of a lot of displaced communities. So there is a grand plan on paper, but when it comes to implementation, there is so little accountability, and people are constantly being made to run from pillar to post. So how do you actually materialize some of these things which should have been there by now, but you only see a further dilution of many of these things with the privatization regime. So fighting that regime on the one hand and also asserting existing rights. I mean, there was a lot of reference to fundamental rights and the directive principles. It's a sad reflection of our 75 years of political journey that many of the directive principles still remain directive principles and are not entirely incorporated within the framework of fundamental rights. So that will continue to be an ongoing struggle within the larger framework of the fight that we're having against the capital. Yeah, I'll stop.
Thank you, Meera. That was really insightful. Your talk, in fact, reiterates one of the criticisms of UHC's narrow focus, which is on financial exclusion, is that it diverts attention from other forms of exclusion and marginalization experienced by several vulnerable groups. For example, on the basis of caste, religion, sex, gender, sexual orientation, HIV status, etc. There is clearly a need to draw attention to other social determinants of health and issues of discrimination and marginalization within the health system. And it'll be interesting going forward, we see what kind of frameworks of accountability does the right to health afford and can present to rights-based UHC. I think the next session was supposed to be like me putting up questions to each of the panelists, but I think we are running out of time. So we are moving straight to the questions posed by the audience. And one of the questions is from Alok Arunam. And he asks that several sociologists like Professor Dipankar Gupta and Professor Andre Betel, I hope I'm pronouncing it right, had differentiated between equality as right and equality as policy. Mere rights-based approaches without sufficient attention to state capacity are not useful. Isn't then the emphasis on rights-based approach not pragmatic enough? I think that all of you can respond to this in turns. You can take a couple of minutes. So should I first ask Professor Puras to respond to this?
Okay. I don't think that the right to health concept or human rights-based approach is not pragmatic. If it is applied in sustainable and consistent way, it can be very pragmatic, and the best example for me is how AIDS epidemic was managed when the message from experts was to stop discriminating key populations. Even those political leaders who maybe did not like this idea realize that this is essential. It's like remedy. And so there was another question to me, I think, but it's about the same. When we all are concerned about how to implement properly the let's say well-formulated policies with the right to health and human rights-based approach present in formulation, I think it's very important about monitoring, independent monitoring on everything what is happening on national policy level, on local, municipal service provision, and on individual, when patient meets health staff, what's happening there. And this is about process and especially about outcomes. And for independent monitoring, again, transparency is needed. So not only academics are needed, but civil society is needed to observe and to signal if something is going wrong. And things are going wrong when or if there is some imbalances, asymmetries, including power asymmetries, gender-based, as it was in Gita Sen presentation, or based on asymmetries between users and providers of services, like it happens in mental health services, when with good intentions, users of mental health services are disempowered, even if biomedical model may be helpful, but because of these power asymmetries which still exist, people are disempowered and not empowered. So this would be my comment.
Thank you, Professor Puras. Can I ask Professor Sen to respond to this now, please?
I'll sort of, reframe the question as whether a rights-based approach is pragmatic enough. It's as straightforward as that. And of course, I would not argue that it isn't. However, it is, one might argue that a legal approach may be necessary, but it may not be sufficient to realize the full implications of a rights-based approach. So the equation of rights-based approach with legal approaches seems to underlie this question. And I think that that's a problematic equation. Rights-based approaches are not only legal approaches. And I think that all of us have been trying to point to different ways in which the meaning of the right to health can actually be viewed from different stances, different positions, different perspectives, and also different disciplinary backgrounds. I would say, however, that secondly, that the challenge is not one primarily of state capacity. It is actually the problem of power. And one of the ways in which power in the context of UHC discussions lies hidden is the fact that UHC itself, in the way that it is often promoted, can become an obfuscation for the larger changes in social, economic, and other policies that Mira was speaking about, and that I think quite often are headed in the opposite direction to what realization of the right to health or of genuine universality of care for everyone would entail. And we have multiple examples of that. One very powerful example that was detailed quite a bit in the former Health Secretary Sujata Rao's book, Do We Care?, was the problem of what happened to medical education in this country. In the name of moving towards having more capacity in the training health providers at all levels, the private sector was invited into medical education. 20 years later, we still don't have enough health providers in the rural areas because of the way in which that has happened. So UHC quite often is promoted as a what, in terms of here's the goal towards which we want to go, while obfuscating the how. And the how of privatization, which has come along with the language of UHC, quite often can be quite challenging. Now, let me say one thing, however, as a caveat to this. I'm not against the private sector per se. I think that there are problems with the public sector if it doesn't have good challengers coming from the other side. The public sector can be mean, vicious, poor quality, and unaccountable. And there's a problem of the private sector if it doesn't have a strong public sector pushing it in the other direction. One of the interesting things about the state of Kerala is that you have this kind of balancing battle constantly going on between the private health providers and the public health system. Anyone, and I've lived in Kerala for 10 years, so I can absolutely vouch for this. Anyone can tell you, purely left to itself, public health providers don't, especially medical colleges and others, don't really provide you with the quality of services that you might want. So it's good to have the private sector breathing down their necks a little bit. On the other hand, you cannot have in health the private sector run rampant and free to do what it likes without a strong public sector to push in the other direction. I do believe, therefore, directions such as the one that Meera mentioned, Niti Aayog's turning district hospitals into privatizing district hospitals, is a recipe for disaster. District hospitals in many places significantly need to be improved. Their quality has to be improved, and they need to be made accountable to the populations that they serve. But calling for accountability is not the same thing as simply privatizing them. Nor are the famous, or should I say infamous, public-private partnerships taken beyond a very limited frame. Yes, it makes sense to privatize laundry services to a hospital. Why should a hospital be doing its own laundry? Of course, it makes sense to get a decent laundry service provider for a hospital. However, that is not the same thing as bringing unaccountable private provision into what should be solidly publicly provided basis of care that anyone can access. And I think that balance is what we need to find for UHC to work right. So it's not a question of being pragmatic, not pragmatic, etc. We need to be pragmatic, we need to be reasonable, we need to use what we have, but we don't need to be driven by an ideology that somehow the private sector will solve all problems. As I said, in maternal health, you let the private sector run rampant and you will get huge rates of C-sections beyond anything that is the WHO norm. You will get huge rates of hysterectomies because hysterectomies for women are the equivalent of cardiac bypasses for men. Women don't have so many heart problems, but we do have uteruses. And so the private sector goes to town with cardiac bypasses for men and hysterectomies for women. And that's what you get when you don't have this balance working right. And I would hope that this Lancet Commission can really work towards spelling out what it would mean to get that balance right. Thank you.
Professor Sen, it's so tempting to carry on this conversation about the path to UHC that we've been down in the last decade, especially the financialization and privatization route, without any accountability frameworks and overarching principles. But we'll have to have that conversation some other time. Moving on to Vivek, your comments to the question very briefly.
Oh, yes, because I noticed we have very few minutes left. So let me actually echo both the previous responses. Dr. Puras talked about HIV. I think, the problem has been that we have lived in our little bubbles in the HIV world, and we've not shown the world what is possible pragmatically in working to actually have a better health response. I'll give you one quick example. And I should also say that the rest of the world has not been willing to look at HIV as a model as much, has seen the exceptionalism and has been pushed away by it. I think a simple example of the pragmatics of how to deliver health. 25 years ago, one sat with the bureaucracy in the city of Bombay. And actually, one of us was gay, the other was a sex worker, the other was a person who used to use drugs, another was an HIV positive person, and we sat with a bureaucrat in the Maharashtra government or the Bombay city government, and we actually explained our contexts. And those bureaucrats' eyes opened up. They didn't open up immediately, but they opened up over time. And they understood the challenges of our inability to access, forget about healthcare, just basic fundamental stuff as just occupants of the city. And thereby, dots were connected on what are the pragmatic ways in which these communities can actually be better served so that their health is protected and the health of larger communities protected. And you saw a change over time. This is painstaking work. This is not work which is necessarily written in policy or law, but this is the kind of work that needs to happen. And this, according to me, is what rights-based approaches also include. I should definitely want to also say that I'm so glad that Dr. Sen spoke about the rights-based approaches not equaling legal approaches. It's quite a different thing. But I also want to say that if you want to rein in the private sector or certainly govern it, you need a legal framework. You have to have a framework which makes it accountable, and discrimination and equality is one of those things that offers a legal framework. So it has to be married with other pragmatic things. It can't be by itself, but certainly the law is not a solution to the problem. It's got to be a combination of things. There's a lot more I can say. I would love to carry it on. And I think I'm going to connect with Dr. Sen and Dr. Puras also, and Meera, of course, later to see how we can carry this conversation on. Thanks.
Thanks, Vivek. Yes, actually the HLEG report has quite a substantive chapter on the regulation and accountability mechanisms for the private sector and can be very instructive in this work moving forward. But now I ask Meera for her final
Which I was responsible for, by the way.
Yes, yes, Dr. Sen, we know.
Yeah. No, I think Dr. Sen has responded very well to the question. But just to add, when we speak of equality, I think we also speak in terms of with an understanding of equity and not just equality. So it's important to again center stage that notion of what we really mean. And of course, yeah, the private sector is here to stay, despite many of our approaches towards what the private sector has really done to public health at a broader level. But it is therefore all the more important to rein in the private sector and to have these mechanisms of accountability. We definitely have had some examples previously, but there are things that have worked, not worked. For instance, the Consumer Protection Act in some ways was a measure to hold the private sector accountable. But it is again, I mean, there are huge limitations of the act, the way it is actually implemented, etc. So I think one also needs to revisit as part of these frameworks, revisit what kinds of accountability mechanisms have not worked, or how is it that the private sector actually finds ways through all the holes in the law and then with their huge cloud. So it's, I think, also important to look at that. But entirely agree with Dr. Sen that there needs to be this pressure as well, because yeah, the public sector can be very difficult. So it's important to also hold the public sector actually accountable. So how does one do that also needs to be part of our discourse. Yeah.
That was great. I mean, it's hard to end the conversation here, but we have to, and I'm sure we'll carry on this conversation outside of the webinar. But thank you to all the panelists. I now hand over to Yamini for her concluding remarks.
I knew when we were going to, when we were conceptualizing this discussion, that it would be one of the most powerful contributions into shaping our thinking. And of course, none of you disappointed. This is such a important engagement for us to have as we think about what are the policy implications of universal health coverage, the dynamics of power, how we need to think about how they shape the patient's experiences with the public health system from the minute they walk in, actually from the moment they engage with the community health worker to when they go to the primary health center and all the way up. And it's in that context then that we can have a discourse around the hierarchies, the structures, the legal frameworks, the regulatory environment. And I think no matter how nuts and bolts and policy we get in terms of what needs to be done to make the promise of universal healthcare a reality, if we don't anchor this in this understanding, then we may fall into the trap of really giving the wrong recommendations. And I think the important caution that was given to us through this conversation, that debating universal healthcare without anchoring it in the foundations of a right to health may end up creating a deepening of inequalities and inequities, which is precisely what a discourse on universal healthcare is seeking to avoid, is something that we need to recognize much, much more seriously. I think also importantly, the discussion around state capacity and rights is an important one. And in fact, in one of my early conversations with Vivek, I had we were discussing the experiences of rights frameworks and other social policies and what impact that has had on the actual ability for creating a governance architecture that realizes those rights. But I think it's a discussion that needs to continue, but again, one that where we shouldn't throw the baby out of the bathwater. The lack of state capacity is not a reason why we shouldn't be debating a rights framework. In fact, the argument should be, what kind of state capacity do you need to enable in order for universal coverage to actually become a reality? And therefore, in some ways, where you're pushing us through this conversation is to really get to the heart of the normative role of the state vis-a-vis health, articulating that effectively and building from there what this architecture of a universal health system should look like, and the relationship between the state, the private sector, and of course, keeping the patient or the citizen at the heart of it. So thank you very, very much. I hope that we can trouble you over the course of the next few months as our own deliberations emerge and evolve. And I hope that, I think it'll mean a lot for us to refine our ideas through a dialogue with all of you. So thank you. Thanks very much, CHELP, for organizing this. It is really one of the most important conversations we've had.